venous varix lesions that we find on patients' lips and on their tongue. Like I said, nobody out there is treating those, so it's kind of a niche market as well for us. So before we do any recontouring, we need to kind of review and be aware of cosmetic principles that we need to follow, and those are the position of the interproximal contacts and how that affects the length of the papilla in the different areas in the aesthetic zone. The location of the zenith, or the highest point of contour, which differs from tooth to tooth. Axial inclination, or the long axis appearance of the teeth. Harmonizing our gingival heights. And here's some illustrations that show that. So contacts between our teeth is what's going to dictate the shape and the length of the papillae. And the highest point, the most incisal point of contact happens between our centrals, and as we move back, that contact point starts to go gingivally. And from the soft tissue standpoint, our longest papilla will normally be between the centrals, and again, as we move back, the papilla shape begins to shorten as we go to the posterior teeth. So as we recreate and do these contouring, we need to keep that in mind. Height of contour, or the zenith position, what we have is it's distal of center on the centrals, pretty much in the center of the facial aspect of the tooth on the laterals, and again moves to the distal of center on the cuspids, and then pretty much centered the rest of the way back. So this is important because anytime we start doing our aesthetic recontouring, we want to be aware that this is our highest point of contour, and typically I will always start in that position and do my contouring from that point in order to make sure I maintain that. Axial inclination, this really more involves the angulation of the tooth, but what soft tissue recontouring allows us to do is, if we've got a tooth that is kind of off with the axial inclination, where it doesn't point to the midline, where it's maybe straight up and down, by cheating the gingival contour, say to the distal, we can give that tooth an optical appearance of leaning more towards the midline, despite not having to move the tooth at all. Just the gingival contour can make that look better as well. And in our gingival heights, where we're going to be the highest on the centrals and the cuspids, which stay on the same level, and then typically, just like lateral incisors tend to be a little bit shorter incisally, they tend to be a little bit shorter gingivally as well. And then as we walk our way back from the cuspids to the first and second premolar to the molar, those gingival contour, or the heights, tend to drop lower as we go that way as well. So my protocol using an erbium YAG laser is to first, by whatever means, you can use calipers. I'll show you a neat little gauge that is very handy to use. You want to determine the proper width to length ratios for the involved teeth. You want to determine the ideal. Sometimes because of what the soft tissue gives us, we may not be able to reach ideal, but we kind of want to know what our ideal length is based on the width. We don't really have a lot of control unless we're prepping and doing veneers. The width of the teeth, we just can work with the length. So we're going to probe the gingival pocket to determine the pocket depth. The probe depth minus 1 millimeter equals the amount of soft tissue recontouring that we have available to increase that tooth length. If we create a pocket depth of less than 1 millimeter, what we're going to do is we're going to get some relapse or rebound. So if we, and that's the kind of the problem in the anterior. Most of the time our pocket depths are no more than 3 millimeters, but typically about 2, so we're a little bit limited on how much soft tissue alone we can do with our recontouring. So if we need additional length and we really want to create a cosmetic result and we don't have the soft tissue to give us, then we have to start thinking about a closed or mini flap osseous recontouring procedure that may be necessary, and that's a topic we can touch on, or a webinar we can touch on later as well, how we go from soft tissue contouring alone to involving the osseous tissues as well. So utilizing, I like the conical sapphire tip. You can use a 600 micron, the Varian tip, Lightwalker settings, 30 hertz, 60 millijoules, starting without water, because you get a better contour and you get better results. using the SP setting, and we're going to sculpt and contour the gingival tissues to the ideal shape and gingival height, obtaining the proper width to length ratios. And then I always finish with the soft tissue recontouring and beveling with the tipless handpiece, which works wonderfully, and utilize water. On my machine, a setting of 2 works great. It doesn't overwhelm. It's just enough water to actually just do the final contouring and clean up the tissue, and then we're going to use light air. And the reason we want to finish with water is that what we leave the patient with is what their post-op sensitivity is going to be. So if we do our last little bit of recontouring with water, the zone of necrosis is so minimal compared to any other treatments out there, even diodes and Nd:YAG, that patients don't have post-op sensitivity with this at all. They don't have to take anything, not even OTC type medications. So I like to use a vitamin E. I'll show you a picture of that to use as a tissue coating when the patient's done. Typically we'll have them apply it maybe 2 or 3 times a day for a couple days, and it's really that all they need to do after the treatment's done. So here's a picture of the conical sapphire tip. It works really nice. Again, setting 60 hertz, 30 hertz, 60 millijoules. Starting off with my water turned off, air at about a 1, and then when I go to finish, usually a 1 setting or a 2 on my machine works great. So a lot of this can be done with topical anesthetics. They got some great topicals out there now. I think most everybody has heard of the TAC 20. Comes in a high and low viscosity. Diclone is kind of a rinse that patient can swish with. That'll numb everything. I've been using it's called BLT, benzocaine lidocaine tetracaine. Galela's anesthetic cream. It's compounded by the Medicine Shop. The phone number's on there. So it's a white pasty gel, and if you leave that on dry tissue for about a minute, it's an unbelievable numbness that they get, and you can easily recontour up to about 2 millimeters of soft tissue without the patient feeling a thing when they use that. Another one is called LTP Thick. So all of these work really, really well. They just have to be applied and set on dry tissue, typically for about a minimum of a minute. So here's a simple case, more of a restorative type case. This has a couple enamel defects where the tissue has grown into those. When you trim these cases, you have to do something with the enamel defect, do some bonding, and then the tissue will hold at the heights that you put it at. Again, sapphire conical tip. Our angle, we want to try to stay parallel with the tooth so we don't get interaction on the enamel of the tooth. I usually say do about the first 80% of the recontouring dry, but the last 20 wet, so that you're leaving the patient with a tissue surface that is going to be comfortable when you're done. This is a case you can do easily under topical. So this is after the tissue's been recontoured and the restorations have been placed, and then that tissue will hold its contour and not fall back into the indentations in the teeth. Another type of case is just one that where the patient looks uneven. When you look at it, it looks like their teeth are 2 different sizes on the right side, central, the lateral, even a little bit on the cuspid. And a lot of these patients don't realize this. It's kind of funny. I will see them on hygiene and ask them about this, and they really, it doesn't draw attention to them until you point it out, and then once they see it, it drives them crazy. I've had a couple that allow me just to do it right there on hygiene. I've had a couple that have come back and said, hey doc, ever since you told me this, I look at it every time I look in the mirror. Can you please even these teeth out? So again, topical, just tissue recontouring, everything looks more balanced. The tooth shape totally changes on the right central and the right lateral when the gingival tissue is recontoured. Clean up, you can see around the white on the gum, that's just hydrogen peroxide. It works really nice to get off the little tissue tags and debris, and said, like everybody knows, the hydrogen peroxide, the white coloration will disappear after about 5 or 10 minutes. This is a gauge I was talking about. It's made by Hugh Freedy. It's called the Choose Aesthetic gauge. They've got 3 different gauges. The first one, it looks like a cross, is for soft tissue recontouring. The second one is for actually bony recontouring, particularly open flat bony recontouring, where you can see where your tissue height is, and the offset gives you a 3 millimeter biologic width setting, so you don't have to, so you know where you are as you're doing your bony recontouring. You know when you're at the 3 millimeters biologic width that you need. And the last one is a flat probe that you can do crestal bone probing when you're doing osseous, either mini flap, closed flap, or open flap type osseous as well. So this is how these work. So we have a case come in, post-orthodontic case. Patient's complaint is my front teeth look very square, where they're literally wider than they are long, so they kind of have the classic chiclet look to them. What we do with the gauge is resting on the incisal edge. We take a look at the width or the color coordination with the width. So in this case, the width of the tooth is at the red, or actually the outside border of the red, and where the corresponding ideal width to length ratio would be is at the top portion of the red on the vertical component of the gauge. So what we can do is hold that up to the tooth, look at our width, and then mark our zenith point at where it would correspond to the length. And that's what we did here. We just took a perio probe and just kind of poked. We're at the zenith position where we want it to be at the ideal length. If we're going to do soft tissue contouring only in this case, we still need to measure that pocket and see how deep that is. If that point is, say, where we give the patient 0 pocket depth, we may have to back off and create the height about 1 millimeter less than that. The result will still be really nice. So this is after we did the recontouring, like using the choose gauge just to kind of guide us as to what the ideal. Again, you could use a calipers, measure the width, do your figures in your head, 75, 70%, of the length, but the choose gauge works really nice and a lot quicker. So here's another case, post-orthodontic case where patient's got a little bit of bulbous papilla. The contours of the teeth look very sharp on number 8, a little bit short on number 9, short on number 7. And just with gingival recontouring, we can even things, balance things out. The other nice thing about the erbium laser that's so unique and makes it so fun to use on these cases is we can control the anterior-posterior thickness of the tissue as well. So a lot of these orthodontic cases or patient come in with thick bulbous papilla, we can not only define them vertically shape-wise, but we can also make them finer, get rid of the bulbousness on the facial aspect of it as well. The other thing to look at as well is when you look at these cases and you're going to start changing the gingival contour, pay attention to the frenum position as well, because sometimes if you raise that contour a millimeter or two, you get awfully close to where that frenum pole is, and in those cases you want to make sure that you treatment plan a frenectomy to move that frenum out of the way so it doesn't pull the tissue up. If you don't treatment plan it from the get-go, you'll end up doing a lot of free frenectomies, which nobody wants to do. So just take a look at the pole and where your end result's going to be with your gingival recontouring. So here's a video showing a post-orthodontic case. And again, everything's lined up. This patient came in and had short teeth to begin with, so these are good patients to inform the patient or the parent that when we're done, we're going to line all the teeth up, but we're not going to make the teeth look longer by doing orthodontics. The way we do that is at the end. Usually I wait about 3 to 4 weeks after the brackets are off and then have the patient come back, and then we can start to idealize the shapes of the teeth better. So this is using the hand piece with that conical sapphire tip. We're parallel with the tooth. We're going to start at the zenith position where we want that to be. We've measured the pocket depth. And always start on the centrals because, again, they guide where everything goes in the arch as we work our way back. So idealize your central contours first, at least on one side, then you can work down that whole side and then move on to the other. And I'm doing that dry, as I said, because the cut is more efficient, so we can remove more tissue. Very, very light to no contact with the tissue. That way you don't start getting the tissue tags or the buildup on the end of your tip. And it actually will cut down on the tissue bleeding. One of the reasons that you get some bleeding is if you're taking a tip and you're dragging it on the tissue, you'll stimulate more bleeding when you're doing this. And as you do this dry, you will notice a kind of almost a cotton candy, I like to call it, appearance of the tissue that gets on the end and gets on tissue. What works really nice too is you can see the high back suction has the little extra hole in it, and I have make sure the assistant has that towards me, because then I can use that to gently wipe any buildup off of the tip as I move along and do this. So again, I like the erbium YAG to do this. You can do this with an ND YAG or a diode, but you're not going to have as much control. You're not going to get as smooth a cut. And you almost have to turn the tip a little bit sideways to get a real good cut as well. And with the ND YAG or anything that has the fiber like that, it's hard to control the papilla thickness. So we've gone from doing with no water to now turning the water on a very low setting and just starting to bevel the tissue. So after we trim it to the proper heights, we get very square edge. Gingival tissue contour is very square, so we want to start to bevel the tissue and do our last little bit of touch-up with it being wet. Again, because, as I said, actually the zone of necrosis they've shown with erbium laser when you're using it wet is less than 10 microns, which is amazing. Compare that to an electrosurge that we used to use that's well over 100 microns. So what I'm doing now, the tipless handpiece works really nice to get rid of that bulky papilla, that bulbous type of papilla that's in the interproximal. And again, it can also be used to do some final beveling as well. I know some doctors that do this procedure with the tipless handpiece, and I've got the Lightwalker that has the red aiming beam. The newer ones with the green aiming beam, I think, gives a much more precise dot. And I could see if you have a Lightwalker that has that green aiming beam, you may be able to even do this contouring totally with the tipless handpiece and not have to use a tipped handpiece at all. So just continuing to do beveling. And again, all this step is all being done with a low volume of water spray. What I like to do also in these orthodontic cases is we make the patients Essex retainers in the office. So when we take the brackets off, clean everything up, we will make them a set of Essex retainers. And then when we go to do this procedure, as soon as we're done with the procedure and have the tissue contour where we want it, we take new impressions and we make them a new set of Essex retainers to hold the teeth, but also to hold the gingival contours, because if they came in with bulky tissue and we send them home with their Essex that they had, now they're going to have this gap between where the old tissue contour was and where the new is, and my concern is that could fill back in. It could just irritate that tissue and cause it to fill back in. So we like to make a second set with an impression immediately after we're done with this procedure, and then they've got that retainer within 24 hours. Typically, we'll schedule this in the morning, and then we'll have them come back in the afternoon or towards the end of our day and deliver the retainer. And we're just using a little bit of hydrogen peroxide to do some cleanup. Peroxide will actually, if you've got a little bit of bleeding in the tissue, the peroxide will also help as a coagulant. So here's that case after orthodontic treatment. What the patient looked like. You can see the bulbous tissue, interproximal areas, and just the short teeth, short cuspids. And that's after we did his contouring. So again, flatten the papillas, even things out as much as possible with the anterior teeth, followed our cosmetic principles, and made him, like I said, made him a new Esthetic retainer that day so we could hold those contours as the tissue healed. What about a case like this? This is where you have a lot of redundant tissue, gingival hyperplasia case, drug-induced. Some people just genetically have this. You see a lot of excess tissue, and I'll show you a case video on orthodontic patients that have a lot of spacing between their teeth, and you close the spacing, you get a lot of that tissue that compresses, gets really thick as well. And then how do we get to this point with it? We use a little bit different technique. Everybody, you're always told to always aim that laser parallel with the root structure of the tooth, but on these cases, start this video, it would take a long time to trim a lot of this tissue out if we do it the way we did the previous case. So what I like to do is do more of a bulk removal of this tissue, and you definitely need the conical sapphire tip to do this. So I will go perpendicular to the tooth. Better yet, as we get gingivally, even at a downward angle, so as we start excising this excess tissue, we actually create a bevel effect immediately. So what I'm doing now is just trying to thin these papilla by going and trimming off a large section of the tissue rather than air abrading it just little layer by layer by layer like we did on the previous case. So we'll do some on the top. On this case, he had a lot of tissue buildup on the bottom. This patient started off with about a 3 to 4 millimeter diastema between 8 and 9, and just a lot of generalized spacing in other areas. And as we brought those teeth together, you can see the bulky tissue that gathered, and even a frenum between 8 and 9. We'll finish this case with a frenectomy as well. But I'm more perpendicular, just trying to excise a larger volume of tissue, particularly in the interproximal areas. You can kind of see that piece of tissue that is coming off in one big section. So again, first step is to just get our gingival shapes, get our zenith point, get our papilla shaped. And once we have things pretty much rough outlined, then we're going to go in and start fine-tuning and beveling, and then thinning those papilla, the bulkiness in the papilla as well. Like I said, you can see the thick papilla, just the redundant tissue that's down in the lower anteriors as well.
So even though you're going perpendicular here to the tissue, your power settings seem like you're at such a low level that that's not going to do any damage to the tooth in any case.
Right, minimal. You'll do more damage to the enamel removing the composite cement that's held the bracket on than you will doing this. Yeah, we're only using 1.8 watts, and then if we're staying at a slight bevel or angle, the amount of energy that's actually interacting with the tooth surface is even below that. And if possible, like you see the angle I'm trying to come at, if I can come at about a 45-degree angle as I remove this redundant tissue, I've already established the outline of my gingival bevel just from the get-go, and it just saves time when we go to the tipless handpiece to finish that bevel. So, you know, two things: low energy setting and keeping that tip at an angle where we're creating a bevel will pretty much negate any issue with you know, hurting that enamel. I mean, to effectively cut enamel, I mean, that's typically I start with about 4 watts of energy to do anything much with enamel. So again, we're at only about 1.8. So now we're going to finish the tissue with the tipless handpiece and just start working on our final contour and just refining that bevel, that tissue bevel. And our energy setting is going to be about the same. We're not really going to change anything. What we're trying to do at this point is not remove a lot of tissue. We're just refining. So if we stay at 30 hertz, 60 millijoules, and we turn the water on a little bit, we're actually, our cutting efficiency drops down, which is exactly what we want. We don't want to go and have a big change in the tissue height or notch out a section of the tissue. So it's just really fine-tuning at this point, creating a bevel with very, very low energy and interaction with that tissue. And again, this is where you can kind of see just that last few seconds is what the tipless handpiece allows us to do so efficiently is thin the papillae just in the anterior posterior type of dimension, is to thin and start festooning the tissue interproximally, which is, there's no way you can do that efficiently with an ND YAG or a diode. You know, the fiber tip just doesn't allow that to happen. It didn't take me long to fall in love with the tipless handpiece on the Lightwalker, that's for sure.
Someone just asked about that the audio is fading in and out. I think there's just some spots here where Dr. Ohmes is not talking, so that I don't think fading in and out. I can hear you just fine, though.
Okay. Yeah, I'm just letting the video run, and okay. So what we're going to do now is he's got a very bulky frenum, pulls down in between where all that redundant tissue. So we've got the papilla between 8 and 9 shaped up nicely, and it was very papilla just was very inflamed. It was very, I'm sorry, the frenum was very inflamed. So I decided to use the YAG just for coagulation purposes as I trim this away. And so we did was just a quick frenum release, raise it up so it doesn't pull that tissue between 8 and 9. And that was part of the reason he had the diastema there to begin with as well, that those muscle fibers went in between 8 and 9, and as we gathered those teeth up, it just clumped everything up in a big mass. So frenum release on that to finish the case. So let's talk about any questions on any of that procedures, but let's talk about ovate pontics is another thing we can do. We see a lot of these bridges. We're taught in dental school to do ridge lap type pontics, which don't really look very real at all. They don't look like they're growing out of the tissue. So, and you end up with a lot of triangles like this, but there's a really nice way that you can use your laser to make these bridges, number one, more comfortable for the patient because they don't trap food, easier to floss because when you floss the tissue side of an ovate pontic, the floss remains in intimate contact the whole time as you go up and around it, versus a concave pontic that the floss comes out of contact. And these pontics look like they grow right out of the tissue, and you can actually make them grow. If done right, you can actually create a 1 millimeter, 2 millimeter probable pocket on the facial aspect of these ovate pontics. So here's a case where a patient had come in with a bridge, anterior bridge. Over time, the ridge resorption caused black triangles. What we did was did our bridge preparation and measured the ridge as to see how thick the tissue was. So how much tissue did we have to create the indentation into the ridge? About 3+ millimeters here. In the anterior, I like to make the ovate sites at least 2 millimeters deep because they look better. In the posterior, you can get by with 1 millimeter, but 2 is great. You want to leave 1 millimeter of tissue covering bone. So that's kind of your minimum. So using a laser, we were able to sculpt out the tissue, the little tissue sites for the pontics to fit into. The other thing with doing these ovate pontics as well is you can recreate the papilla shape, where a lot of these edentulous ridges come in and they just flatten out and the papilla shape is completely lost. As you sculpt these out, you can recreate papilla that naturally go in and fill the gingival embrasure of your prosthetic work. So
hey, Jay,
this is, yes.
On that last case, there were 2 other questions.
Sure.
First one was, do you turn down the illumination to see the red aiming beam better? And then the second one was, do you reapply topical for a lengthy procedure like that?
Yes and yes. So if you turn your light down or do it indirectly, maybe shine it on the patient's chin, your aiming beam, the red one shows up better. The green one, I don't think it really matters. That is so intense that you can see that even with your overhead light. But yeah, I'll have to pull the light off of the patient directly and put it on their chin, and then you can see it better. And then yeah, on a longer procedure like that, or if you're removing more than millimeter, 2 millimeters of tissue, then reapplying the topicals is a good idea. Topical will last about 10 or 15 minutes. Or it'll penetrate 1 to 2 millimeters. So if once you trim away and that patient starts to feel a little bit, you can go ahead and just re-dry things and reapply the topical as well. So again, you can see the final case and how the teeth just look more natural coming out of that tissue. And what I like is now you've got papillae reintroduced into the gingival and brazier areas as well on these bridges. So this is a video that's it's a different laser. I had a Conbio laser for probably about 8 years prior to getting to the Lightwalker, and this is how we would do the ovaponics with that. The Conbio system did not have a tipless design. So what you want to do first is outline, number one, measure to see how deep you can go with your laser or your Pontic site and still maintain a 1 millimeter tissue thickness over top of the bone. But you want to outline your Pontic form, and what you want to consider is what that tooth would look like. So if it's a bicuspid and you were to amputate or cut that tooth off at the gum line, what is that root shape that you're left with? And that's your Pontic design. So it's going to be different on a central incisor versus a molar. So you want to create that trapezoid or triangular or oval type design and do your outline first. And if you're using the tipped handpiece, you can use that conical sapphire to do that. And then once you go 2-3 millimeters deep, however deep you want to, then remove the tissue with a chisel tip. Or what I do now with the tipless handpiece, it works so well, is I do everything with the tipless. So I'll just outline, still cut my outline with the tipless handpiece, and then just go ahead and sculpt out that tissue using nothing but the tipless. The key points to get a nice aesthetic result with this is on the facial and even the palatal aspect is you want these walls to be vertical. So when you set that Pontic down in there, you don't want to bevel these out. You want these to be vertical, but you want to go ahead and bevel the interproximal and reshape them into a papilla shape. And then, like I said, when this Pontic, when the lab goes and makes this ovaponic, which should be completely convex on the tissue side of it, it's actually setting down into this tissue, and that's how you can get a 1-2 millimeter probable pocket, quote-unquote pocket, on the facial or palatal aspect of the teeth as well. So another procedure which I've kind of offshoot, and I'll talk more detail in a future webinar, is being able to take that tissue that we're going to use, that we're going to uncover, say, an implant or use for an ovaponic site, and actually use it to enhance an atrophied ridge. So if we've got a ridge, a dentulous ridge where this is dipped in, the alveolar bone has dipped in, and we want to enhance that, then what we'll do is we'll do a 3-sided cut on this Pontic site, leave it attached on the facial aspect, lift it up, and then actually remove the gingival epithelium, leave the connective tissue, and we can tuck this on the facial aspect of this ridge to plump that ridge out, create our Pontic site, as well as creating a ridge all in one procedure. And call that a laser-enhanced connective tissue ridge augmentation. And this just shows a case where we were missing the tooth, and then we went in and created, this is actually an uncovering of an implant. So instead of just cutting that tissue out and throwing it away or getting rid of it, we actually used it to plump the ridge out on the facial aspect of our implant restoration. So hemostasis, any bleeding that we're getting after procedure can be controlled with 2x2 gauze, just using some pressure. Like I said earlier, hydrogen peroxide or just over-the-counter hydrogen peroxide works really nice to if it's just bleeding a little bit. And then you can use Hemodent, Viscostat. If you're getting impressions or doing a scan, I use the iTero, so it's real easy to scan these Pontic sites. Expasil works nice to squirt in there. That's a Kerr product. Have the patient bite on a cotton roll for about 3 or 4 minutes. It'll completely dry that up as well. So, but one of the keys, like I said, is the less you touch the tissue directly with the laser tip, the less bleeding you're going to get. And that's one of the benefits of using the, for Pontic sites and finishing, using that tipless handpiece. Works really nice because it's totally non-contact. Again, vitamin E, I just go to the GNC and buy a container of these just oral supplements. They work great as little uni-dose handouts you can give the patient. All the patient has to do is poke them with a pen, squeeze them right up on the tissue. We put them in a little coin envelope, give them a couple dozen, and like I said, they're just kind of a built-in uni-dose vitamin E capsule that they can use to place on a fibroma removal, a frenectomy, or gingival recontouring, any type of soft tissue type of recontouring or procedure you're doing with the laser. This works really good. I'm going to show you a venous varix hemangioma removal. We see a lot of these, like patients come in and have these on their lips. Usually women have them coated with about 3 or 4 layers of lipstick because they know they're there and they don't like the look of them, so they're trying to hide them. Even some of the case on the left is actually a gentleman that, you know, just bring it to their attention. And I've been told by patients that they've talked to their dermatologist about these, brought it up to them, and a dermatologist has told them that they'd have to go in and actually scalpel away or cut away part of their lip to do this and actually talk them out of it. So I said the dermatologists aren't doing this. We with our lasers, we can do this really easy. You can do it with either the erbium or the ND-YAG. I like using the ND-YAG. It just works better. 20 hertz, 2.5 to 3 watts setting. 30 to 60 seconds treated non-contact on this will shrink that lesion up. Some of the doctors I talk with are using things like a piece of ice over the top of it or a cold slide and shooting it right through there. Depending on the size of it and the depth of it, if it's a real small one, you can not even touch the lesion and just dry it up. It may take a couple applications to get it completely dry. If it's more of if it's a deeper and a real bulbous type lesion, there's usually some areas of blood pocketing that you have to remove to totally eliminate that. And that's what I mean down here. Remove the lesion to the basal cell layer, and then you can completely keep it from coming back. Here's a video showing just the interaction of these lasers with the diode or ND-YAG wavelength. So non-contact, we're just treating the periphery of the lesion, going around the periphery, and you'll see just in a matter of about 15-20 seconds, this lesion goes from being domed to inverted. It shrinks up. This is a pooling of blood with feeder vessels, and we're treating the feeder vessels first. And once that pool or pond of blood doesn't have the blood flowing into it, it actually shrinks up. So in this case, I'm going to go in and actually, and this patient is numb for this, and we're going to remove tissue and get down to the pockets of blood, and you'll see as we penetrate down, we'll actually invade those pockets of blood, and you will get some bleeding. So if this happens, don't freak out, because once you get down to the pockets of blood, you'll all of a sudden, boom, there's one of them right there. So it was just blood that was trapped into a little chamber, and this one actually had 2 different chambers. As I started drying it up a little bit more, I actually found a second one. So at this point, what I'm just looking for the lesion, it's the little area of the lip is oozing a little bit, and we're just kind of drying it up and stopping the little bleeders so the patient has a completely coagulated lip area before they leave. So at this point, just clean it up, use a little peroxide, put some vitamin E on it. They just apply vitamin E for a couple days. And typically, let me go back a slide, typically after about 2 or 3 weeks, their lip will look like that. So after about a week, you'll have a little remnant, and then within about 2 to 3 weeks, everything is completely gone, and there's no sign of that lesion at all, and it doesn't come back. So we'll see these occasionally on the tongue. Here's a couple different cases where patients have had these hemangiomas on their tongue. and you just use the same technique. Either you can just treat them a couple different times to just shrink the lesion and basically dry it up, or you can go in and actually obliterate the little pocket of blood and dry that up as well. And usually if you do that, it's a single treatment on a lesion this size. Again, after they're done, they don't come back. Looks totally normal. And occasionally you'll get a crazy case that walks in your office. This is a patient that was referred to me by another dentist who knew that I used lasers. And this patient had this lesion going on for at least 20 years, she said. Her consultation with her doctor told her that what he told her they would have to do is section a portion of their tongue to treat this. So you can see why she had this for 20 years. Who would do that? So this very large lesion on the underside of it, you can see how big a varix or hemangioma this is. So the way I approach this, I told the patient right away that there's no way I'm going to get rid of this in one session. What my goal would be to shrink this down, to try to shrink it down by at least 50% with the first session, and then go back in a second phase, treat it again, and maybe even a third phase as we just eliminated this. So what I did was just used a little bit higher power setting, spent a little bit more time on it, wanted to see that lesion actually start to shrink or invert. I wanted to see it blanch, which it did. And then went in, did a little incision into the area where the blood pooling was, got drainage, dried everything up, used a couple sutures the first time, and then sent her home and didn't do anything else for about 2 to 3 months. So this is about 2 weeks post-op, what she looked like. Had her come back in the office after about somewhere between 2 and 3 months, and this is where she was at that point. So now this lesion, I not only got 50% reduction, I probably got closer to 2/3 or even 3/4. So when I looked at this was no bigger than what I showed you in the previous cases with the 2 tongues, much smaller, much easier to deal with. And again, just treated it that same way, went in with the laser, lower power settings, less time, got the blanching, got the inversion of the lesion, and again went in and just incised where the blood pooling was, got it to drain. In this case there's a product that's out there called HemCon. It was developed by the military for gunshot wounds to put over. It's actually just coagulates, even arterial bleeding is what they say. I know Patterson has it, Sullivan or Henry Schein has it. You can cut a little piece of it, stick that on the area that's bleeding. If you remove a fibroma or anything like that, it's a nice little thing. You hold the patch on it for about 10 or 15 seconds. It'll stick. It'll dissolve away after about an hour, and the bleeding is completely done. It doesn't come back. So I just wanted to try it on this case. It worked great.
Hey Jay, there's another question here. Have you ever removed pigmentation on the tongue?
I've done it on the gums. I have not removed it off of the tongue. So your pigmentation is all an epithelial layer. So if you're doing it on the gingival tissue, you're going to go down to the basal epithelial layer or down to connective tissue. You don't have to go any deeper than that, and that'll remove it. And depending on the extent of it, you may have to kind of treat it a couple times, do a portion of it, let the patient heal up and go back. What's harder is amalgam tattoos because they're all the way down into the connective tissue. You literally have to go down to bone to get that stuff out of there. But I have not done it on the tongue, no, but I've done it on gingival tissue.
So on gingival tissue, are you just ablating with the erbium YAG?
Yep, just take the erbium YAG. The tipless works great. Just ablate the pigmentation down all the way through the gingival epithelial tissue, and then it'll just let it grow back in, secondary intention, and that pigmentation won't be there when it grows back in. So you eliminate it. It's all in the gingival layer. So just like again with this case, two steps, completely got rid of a large hemangioma. That patient really didn't have another option. So lasers are pretty cool. So if anybody has any questions that come up later, you can take down my email address. Just shoot me an email. I'd be happy to answer questions. If you get into a procedure or have one of these procedures coming up and you just want to touch base with me for some detail. But yeah, if anybody has any questions now, feel free.
I don't see any more questions right now. Thank you very much, Jay. It was a great presentation, very informative, and we really appreciate you taking time out of your busy schedule to do this for the group here.
My pleasure, Keith.
Great. Thank you very much, and good night, everybody. We'll see you at the next webinar.
All right. Good night.